It's time to focus on seniors with Helping Seniors TV. The television show designed to make you aware of senior issues and needs, as well as to acquaint you with the resources available to help you age in place and with dignity. Now, here's your host, Joe Steckler.
I'm Joe Steckler, and welcome to Helping Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is hearing loss and audiology. And joining me is Dr. Karen Cowan-Oberbeck, the audiologist of ear care, and Glenn Overbeck, the instrument specialist of ear care. And it's fair to say, you have more than one audiologist, right?
No, I'm it.
You're the one?
I'm it.
And you have 3 stores.
We have 3 locations, and I do all the diagnostic testing at all the offices. So I travel.
Holy mackerel.
The nice thing about that is, Karen, doing all the diagnostics, we have the ability as providers to do the fittings and then give them back to Karen for validation. So it is almost like it's a 2-tier type system where we identify the patients that are getting the best treatment, best assessment, and follow-up care. It works very well for us.
But do you have an instrument specialist at each place?
We do.
We do. There's a hearing instrument specialist at each location that's there all week long. I do testing on specific days of the week. And that's something that we do a little bit differently than other places. We have a little different model that way, but that way we're assured that every single person that comes to our practice is having true diagnostic testing by a professional.
Okay, that's why I even ask another question. How about explaining how you're different from other, like you have optometrists and retina specialists, and you have all this stuff with the eyes. How about the ears? What kind of specialists do we have for the ears?
So when we do our testing and validation, the importance of what we do different from everybody else is how we validate our fittings and ensure that the patients are getting the best outcome. Dealing with hearing loss, we don't hear with our ears, we actually hear and interpret with our brain. Cognitive ability to process sounds is extremely important. So we can test the hearing aids all day long and they should test okay, but we want to know how the patient's tolerance and perception of those sounds is.
Whether I hear or not.
Whether you hear or not, and at what frequencies, and at what discrimination levels. So the testing that we do, it tells us exactly what adjustments we need to make based on your tolerance levels.
Many people don't understand that it's more than whether or not there's noise in your ear. I get all kinds. I wear hearing aids, and if it's loud, that's one thing. I have a hard time understanding the TV. I have a hard time if there are a lot of people in a group and everybody's talking. I can't pick what the word is out of the whole clutter. Another thing that I've had audiologists and all the hearing aid people I've worked with explain to me is that there's such a thing as word comprehension.
Exactly.
And perhaps, both of you. Tell the viewing audience why it's so hard for people that have a hearing problem. What should they be going to do to correct their individual problem? Describe some of the situations, both of you. You know what I'm talking about.
Absolutely. Hearing loss isn't all or nothing. Usually you have hearing loss at certain frequencies and maybe not at others. And what that creates are sound gaps or sound voids in your hearing. And so that's why it often sounds like someone's mumbling or people are not speaking clearly. If the TV's not coming through clearly, you hear it, but it may not be crystal clear because you've got pieces and parts that are missing. So the goal with amplification is to fill in some of those voids and those gaps so that it becomes a more complete signal. The better, more complete signal you send to your brain, the better your brain works.
Well, I agree there.
And you had mentioned earlier that you can make sounds loud, but that doesn't necessarily make them clear. The whole idea is to give you the area of usable range in sound without exceeding your max power output or loudness discomfort level. So when we do our testing, we identify what your tolerance are for hearing the threshold, but also the loudness levels, because we don't want to exceed that. Now, it's really, the biggest complaint of hearing aid users is background noise, and it's always going to be, because hearing aids are designed to amplify speech. Well, when you get into a multi-group environment with multiple speech people, you cannot identify between pattern A, C, but not hear B. The realization is that no hearing aid has the ability to dial in on one person but filter out the others. What they do is have directional microphones. So the microphone polar pattern of how we hear behind, beside, and in front has the ability to narrow down in beamform so that we can focus on the person we're looking at. It works better, but there really is no way to control background noise when it is multiple speech patterns. So because the hearing aids are designed to amplify speech. Some of the ways that we really have improved over the recent years is with what we call connectivity, wireless Bluetooth connectivity. Today's hearing aids have the ability to be paired with a wireless device, a portable microphone that somebody else could wear, sends the information or the voice from the microphone directly into the hearing aid or into a streamer. You can also connect it with a television or a phone, a smartphone. Computers. So the biggest change that we've seen is in the connectivity of the devices to be able to pair and send you what we call direct audio streaming or input.
Do you have to wear that, or did you wear it just to demonstrate?
No, I do wear. I've worn a hearing aid since 1989 in my left ear. My right ear is perfectly normal. So advantage to that is I have the opportunity to try every new device that comes out. And one of the things that we really pride ourselves on is understanding all of the technologies available to the consumer, no matter who makes the hearing aid. So we're able to program all of the leading manufacturers. So it gives me an advantage.
I'm going to ask you a question. It might be too leading, and you may not be able to answer it. And if you can't, I understand. In your experience, doctor, what have you found to be the best all-around hearing aid?
Oh boy, the one that you get up every morning and put in your ear and wear from morning till night. Yeah, that's the best one. It has to be something you're comfortable with. It has to be something that you're motivated to wear. The style often can be determined by the type of hearing loss that you have, but that's not usually the crucial issue. It's you've got to want to wear it. Okay,
now I have my left hearing aid. When I took my hearing, I hear half my hearing now, but I found that this left hearing aid just wasn't going in my ear right, and the technician out at the VA said it needed to be ground down a little bit. Yeah, so he did that. It fit in my ear, and it was more comfortable. Before it felt like it was coming out all the time, and I would suspect that many people that wear glasses or have hearing aids are reluctant to tell the audiologist or the eye doctor that these don't feel quite right. They don't feel comfortable, and they try to make do with what they have, and that's a big mistake.
It's the biggest mistake. I can tell you one of the advantages to one of the programs that we offer is called Patients for Life. Well, what that means is that we see our patients at least 3 times in the first month to make sure the fit is good, make sure it sounds good, make sure they're trained properly. We will actually ask our patients to complain. That's their job, and our job is to find solutions. So by tracking them and following up on a regular basis, we're able to identify not only through the performance of the hearing aid, they have what's called data logging. So the hearing aid has a computer inside of it that is actively monitoring. So based on the data logging of the wearer's preference, time, environments, we can make adjustments according to that. But the physical fit is priority 1. It has to fit well, it has to sound good, and you have to be trained properly.
Well, like the audiologist explained to me out at the VA that these things talk to each other.
Correct.
They do.
And you really can't tell that. But I've had the kind where I had a control in my pocket that would shut the things off. It was I could shut off the noise to the side of me. But I found it was too hard to try to remember to correct for all situations. And I think once I got the type of hearing aid I have now that I feel more comfortable with, but I still, and I don't know if this is a common problem with wearing hearing aids or how the two of you could address it. Let's say that I go to church and I happen to be Catholic, but the priest walks back and forth and turns his guy's back to you, and they wear the earphones, the thing on their side of their face, and the mic is in the front. And some of them talk louder, some talk lower, and they'll talk loud, and then they'll talk softly. They'll tell a joke, and they talk faster. I look around church, And I see a lot of people reading a bulletin, sleeping, or just nodding off in space.
It's a big problem. And I can tell you, if you're going to go to church, you want to hear the message. That's why you're there.
Yeah.
Direct audio input is ultimately, go ahead and explain.
No, I was just going to talk a little bit about the Americans with Disability Act, which provides that any place that broadcasts to the public has to provide some kind of entity for you to be able to link into their system. Not everyone will offer that to you. So whether it's a place of worship, if it's the King Center, if it's any place, again, that broadcasts in some way to the public has to provide some kind of adaptation for you. If you have what you were mentioning, the direct audio input, that should connect you directly to the in your case, the priest's microphone, which gives you direct access to that message versus the sound bouncing all around the room before it gets to you with your hearing aids. And they have different forms. It could be a headset, it could be an earbud, it could be a loop system where you can actually connect through your hearing aid.
Well, they have the earbuds over at Holy Name, and you have to put that thing in your ear.
So you would take your hearing aid out and put that device in.
And that could defeat the purpose, because you want to be able to hear through your hearing aid because it's adjusted for your hearing loss. One of the bigger changes that we're seeing coming now is what they call telecoil looping systems, where you can actually use your own hearing aid to get the direct audio input. It's just a matter of activating a telecoil. So that's going to help a lot of people otherwise.
Yeah.
And different public places have different systems. So you actually would have to ask at each individual place that you go, if it's a church or a theater or the movies.
But what you're doing, Doctor, is you're making a case for all of us that are hearing impaired. We encounter so many difficulties in trying to hear. If I go to talk to a group of people, I get questions all the time. I can't understand what the people are asking me. I can't do it. So I ask somebody, could you please have them speak louder, or could you tell me what they said? And I've learned not to be bashful about it. I just ask.
And you should take responsibility for it. We tell our patients that are severe to profound with hearing loss that they need to take control of their hearing loss, whether it be at the airport checking in or a different environment where they have to have better communication to let that person know that they are hearing impaired. See, one of the bigger frustrations also is that if people assume that if you have hearing aids in your ear, you should be hearing perfect. Reality is, we are working with what we have remaining in the nerve damaged areas. So if you have hearing loss, the earlier the onset, the earlier the detection and the treatment, the better the patient or you will do long term. So we're finding that people are waiting 7 to 10 years longer than they should. And that's an issue also.
How about...
But you do have to be your own advocate. And one of the things that you can do, even when you have hearing aids, again, hearing aids are not like glasses. They don't correct your hearing. Hearing aids can only utilize what hearing you have left.
Exactly right.
So that word understanding score you were talking about earlier, if your score is, say, 80% word understanding, even with the hearing aids, that means 20% of that information is still missing. So where do you get that extra 20%? That you have to accomplish by having people face you when they speak. It helps if I slow down when I speak. If I'm speaking too rapidly, your brain can't play catch up. It's always playing catch up, trying to fill in those gaps, those voids, those missing pieces. So one thing that you need to say to people instead of I can't hear you is specify I can't understand you.
I tell people that.
And then you have to tell them what to do about it. And that is, you need to look at me when you speak. You need to speak more slowly, and I'll get it.
It's just like me being in one room in the house and somebody calling me from another room.
Not happening.
And not understand why I don't understand them. I can't.
It's frustrating.
You know they said something, but you didn't understand what was said.
That's exactly right, Doctor. And this is the hardest thing, and it becomes a frustrating thing because there are more hearing impaired people than I think we want to admit. Do you
over
have any
25 million
I
untreated in the U.S. Over 25 million with hearing loss in the U.S.
in the United States?
Correct.
Yes, I actually had some numbers for that. Go ahead.
Go ahead. Did you find it? We'll keep talking.
Okay, keep
You'll
talking.
find it.
Yep.
What what, and if somebody really, let's talk about the frequency loss.
Mm-hmm.
I was a submarine officer for years,
I have a
and
lot of
with
your
diesel
friends.
engines, and I've told that when the audiologist looked at my chart, showed me that my hearing loss went like this, and like this, and then it came back up.
Right.
So that means, and that's what you're talking about in that 20 or 30% comprehension spirit, that I'm not going to understand what people are saying, no matter what I do.
So it's interesting because technology is really addressing better ways to communicate, help you communicate. Now, one of the technologies that is really showing improvements is something that we call sound transpositioning or sound lowering. Those areas in the frequency of your hearing loss may be so damaged that you cannot amplify those to hear them again. So what there is a technology that has the capability of compressing that frequency response into a lower octave to make those sounds audible again. I have a patient that has a diabetic pump. He cannot hear that pump when it goes off. When we activated the sound lowering, he was able to hear that pump, which could be a life-saving change for him. Doesn't sound the same as it did prior, but you're able to audibly hear those tones, and that helps a lot of people.
And almost all the television shows I've been in recently, the business of diabetics has come in.
Yes.
And I'll ask both of you, what is the significance of diabetics and with regard to hearing loss, and what people should do, or can anything be done with diabetics to improve hearing?
Absolutely. For years, it's been known the vision connection and diabetes.
Right.
But only maybe in the last 10 years or so has it come about that we've figured out there's a connection with hearing as well. Obviously, we would like everyone to have a hearing test. If you're over age 50, it's probably a really good time to have a diagnostic exam and establish a baseline. If everything's great at age 50, then at least you have a starting point. So if there are changes down the road, you can modify and see how long it's taking you to get from point A to point B.
Right.
But it's also connected not only to diabetes, but to other quality of life issues like depression and feelings of exclusion and isolation. It changes your social life.
I agree with everything, because I've got hearing loss, but I'm not going to let it affect my social life. And I made up my mind, I'm not going to let it affect it.
And the most important thing is the cognitive decline. That was the number I was looking for. Even mild or moderate hearing loss is sufficient to double the risk of cognitive decline and to triple the risk of falls in elderly people. So because your balance system and your inner ear are connected, so balance and dizziness and stability are all also related to hearing loss.
You know, I never thought of that. I have fibromyalgia. So I'm in pain most of the time, and it's just a fact of life I've learned to live with. But I never thought about the fact that my hearing loss could also be affecting my sense of balance along with the pain affecting. Am I making sense?
Yes. Absolutely.
Is that really true? I never even thought about that.
Well, actually, there's another condition of the ear called tinnitus, or ringing and buzzing, which, again, millions and millions of people have. And chronic pain and tinnitus actually have a lot of parallels in how they are handled by people.
Okay.
Because it never goes away. It's constant. It can be debilitating depending on how much
What'd you call that?
Tinnitus, or some people say tinnitus. Depends on where you went to school, but tinnitus, and that can be a range of things. That's not just ringing in the ears. It could be buzzing or crickets or the ocean. Some people hear tunes. They hear music. Or
is that kind of a common thing?
Very common, especially with folks with hearing loss.
Common enough now that the manufacturers of hearing aids have built-in algorithms that have tinnitus masking, so that you can actually activate the device with a tinnitus masker. And what it does is it gives you a calming sensation. It's not going to make it go away, but it is a masking sensation. And we have many different apps through the internet that I tell people to go through and search for tinnitus management. It's as easy as just using a smartphone with a pair of earbuds, finding the tinnitus management sites for free, and then downloading which ones work the best for you. It's a free app that you can use without even having to purchase hearing aids or other masking devices.
A thing that I hear from a lot of people about implants in the ear, doing the Was it on the inner ear where they put that?
Well, there's different types of implants.
One of the ones is where a piece of bone or something.
A corrective measure for a middle ear problem? Is that what you're thinking of? Okay.
No, let's stick with the hearing thing.
Okay.
What kind of implants? I'm not talking about putting a device in, but I'm talking about doing
surgical implant.
Yeah, surgical implant.
Okay, there's two main surgical implants. One is called the Esteem, and that there's nothing visible. It uses your own mechanism to amplify the sound internally. There's a certain type of hearing loss that's applicable for. There's another implant called the cochlear implant.
Cochlear implant. That's what I'm thinking about.
Right. And you have to have a pretty severe hearing loss to be a candidate for that.
Is that right?
You do. And a lot of people have asked us about those. Hey, can I just get one of those implants? Probably not, unless you have a very severe hearing loss.
Do you do those things?
I do not. And I wouldn't recommend you do that anywhere locally. Typically, we refer folks to either University of Florida, to Shands, to the Mayo Clinic in Jacksonville, to Miami, to the university. Any place that does this procedure on a daily basis is someplace you want to go.
Okay, I'm putting myself, I'm hearing impaired. I wear hearing aids. I've had so many people say, well, why don't you get an implant so you can hear better? There's no sense.
The implant's appropriate when your word understanding reaches a level below 40%.
Your word understanding.
Correct.
Discrimination.
Your word discrimination. Okay. Or you've dropped so far down on the chart that a hearing aid isn't going to help. The process of putting in the implant wipes out your inner ear. So if for any reason the procedure was not successful, you would no longer have hearing in that ear. So it's imperative that it go in an ear that has nowhere else to go. But it's becoming the standard of care for people that do reach a level of that hearing aids aren't helping anymore.
Profound.
But they go in they're putting them in babies now, and there's no upper age limit as long as you're a healthy individual and can tolerate a surgical procedure.
They're putting an cochlear implant in a baby?
Yep. As young as just a few months old, because now babies are being universally tested in the hospitals before they even leave, so they can identify hearing loss at a much earlier age. And hearing is so important for communication and, again, that cognitive development for speech and language.
Wow.
So it's become a great procedure.
So that's something that new parents should be thinking about.
Yes, and it's typically their babies are screened before they even leave the hospital.
They are?
Now. Most hospitals have adopted what they call universal screening now, and it's done before they even go home.
And one thing you both have said that I appreciate your saying on the show, when you say you shouldn't have something done here, you should go someplace else. So many people are afraid to say that. Many doctors are afraid to say you can't be helped. They always want people to have hope. But when I find a doctor that says, be careful, be leery, you could lose, you could do this, you could do that, then I want those people to talk to the audiences that I address more, quite frankly, because I think it's important for people that have hearing problems to get the right information. Is it a fair assessment to say that, generally speaking, you can help somebody that's got a hearing problem? Can you help them?
Almost everyone. Almost everyone.
You may not be able to do it to the extent that it's perfect.
Correct, and that's where realistic expectations come into play. And before we even get into the fitting process, the diagnostics again tells us what our potential of hearing better is. The discrimination scores will be our target when we identify what their ability to hear is. And we're going to tell them exactly what their realistic expectations are going to be. Now, we wish we could make everybody perfect, but it's not a reality. We have to identify and give them the best resources, best testing, best fitting strategies, best protocols in order to achieve the best outcome. But we're straightforward with them, and you have to be.
But you brought one important you did, doctor. There are two things involved in hearing: the loudness of the sound and the comprehension.
Yes.
It may be loud enough, but you still may not be able to comprehend.
Correct.
And that's where you score 60, 70, 80% on your comprehension, correct?
Mm-hmm.
In my hearing loss, in that one range, I have about a 40% comprehension. And sometimes I've had my granddaughters repeat a consonant to me at least 7 times before I understood the word they were saying.
Yeah.
Mm-hmm.
No matter how hard I tried to listen to it, I simply could not hear it. I could hear it, I couldn't understand it.
Right.
And you may have what we call a dead zone. You may have a part where the hearing has just been so far damaged at that particular frequency that all the sound in the world isn't going to bring that back.
Okay, we don't have a lot of time left, but
Okay.
one thing we haven't talked about is testing. You both have mentioned it, but I wish that in the time you have left, if both of you could talk about testing, how much it costs, and how people should get it done.
Okay.
Okay, go ahead.
Well, I'm really passionate that the testing should be done by a board-certified audiologist.
I agree.
That's a number one. And going back to a little what you said earlier about not being afraid to refer out. That's part of what an audiologist does. Is they do the diagnostic testing, and if it's not something that can be helped with a hearing aid, we have the know-how to get you where you need to be to get the help you need, whether it's medical or whether it's surgical. We're happy to pass you on to the right place, but audiology is the place to start. Most diagnostic testing is covered by all insurances. Medicare covers hearing testing. They
Right.
don't cover the cost of hearing aids.
Let's say if somebody didn't have anything, if they came in and wanted a test, how much would it cost?
Typically,
ballpark.
if you're a senior, we try to give, even if you don't have insurance, we give you the Medicare price, which is, I want to say, $67
Right
and
around
change.
67.
It's not expensive.
Okay, no.
It's very cheap. It's very cheap.
Yes.
So we're out of time, and I think that I think we've made the point with a lot of people that'll be watching a show that testing your hearing is extremely important, and you can't ignore it.
Agreed.
So thank you both for being here, and I want to thank you, viewer, for watching today's episode of Helping Seniors. I hope you've learned something about your ears. I'm Joe Steckler. Thank you for joining our program today. I'd like to remind you that our senior information line is available to you at 321-473-7770. There you can get help and direction that could be helpful for your specific situation or circumstances. The work of helping seniors is very important, but we can't do it alone. That is why our sponsors here in Brevard County are so important. I'd like to thank our many area sponsors, businesses and medical providers who support the mission of helping seniors that help us carry the cost of our media efforts. If you'd like to join us either as a business partner or simply donate as an individual, we would welcome your call at 321-473-7770. You are always welcome to visit our website at www.helpingseniors.brevard.org. Thanks so much for your help. It does make a difference.